Assalamu alaikum. This lecture is about abdominal wall hernia. Here, just a quick reminder of the definition. The hernia is a protrusion of a viscus or part of the viscus through an abnormal opening in the wall of its containing cavity. The hernia is composed of three main parts: the sac, and outside is the covering of the sac, and inside the sac is the content of the sac. And the sac can be subdivided into four parts. That's the mouth, the neck, the body, and the fundus. Probably the neck is the most important, as this narrow part can play a role in giving the patient signs and symptoms. Covering here, as you can see, the skin, the fat, and followed by the hernial sac, and the muscle or the deep structures here can be part of the neck and the mouth of the hernia itself. The content of the hernia can be variable, could be a viscous or any abdominal viscous apart from the liver. The common content are fluid, omentum, small bowel. Part of the bowel wall could be included in the hernia, and that's called Richter hernia. Part of the bladder as well, called diverticulum of the bladder, the ovary, fallopian tube. Meckel's diverticulum is by definition letters hernia. The natural history: the hernia could be reducible, it can become irreducible, and also can become obstructed, and eventually, if not treated, becomes strangulated. Further build-up of the pressure, further impediment of the venous return. Eventually, there will be obstruction of the arterial flow, and that will eventually cause bowel ischemia. Meanwhile, due to the loss of the blood supply, the integrity of the bowel wall could be compromised, leading to bacterial translocation, and if that's not relieved quickly, gangrene will ensue and perforation and peritonitis. Clinically, the patient with reducible hernia, the patient will suffer from a swelling which can be reduced spontaneously or manually. If the patient cannot reduce the swelling, this is by definition irreducible hernia. If the patient suffers from the symptoms of bowel obstruction, such as abdominal pain, nausea, vomiting, abdominal distension, and constipation, this is by definition obstructed hernia. And if the patient starts to suffer from increasing pain and tenderness over the hernia, generalized abdominal pain, fever, sweating, then that will raise the suspicion of the strangulation of the hernia. There are several types of hernia. The commonest are inguinal, femoral, umbilical, incisional, and epigastric. The less common hernias include spigelian, gluteal, obturator, and lumbar. The hernias occur usually at the site of weakness in the abdominal wall. This weakness could be normal or physiological, such as in the inguinal hernia, or could be acquired, either due to disease or trauma. Risk factors for hernia development include chronic cough, constipation, pregnancy, straining admicturation, severe muscular effort, and ascites. All of these will lead to increase in the intra-abdominal pressure, and developing of hernias. Here, just a quick reminder of the anatomy of the inguinal region. We have the superficial and the deep rings. Superficial ring is triangular opening in the aponeurosis of the oblique muscle, external oblique muscle, and it lies about 1.25 centimeter above the pubic tubercle. Usually it does not admit by the tip of the little finger. The deep inguinal ring is a U-shaped condensation of the fascia transversalis, and it lies about ½ inch above the mid-inguinal point. Inguinal canal is an oblique passage in the lower part of the anterior abdominal wall, and it extends from the deep to the superficial inguinal rings and directed downward, forward, and medially. It's about 4 centimeters in length. This is just a diagrammatic representation of the inguinal canal. And this is another representation of indirect inguinal hernia. That's the bowel going through the deep ring, through the inguinal canal, and descending to the scrotum. Boundaries of the inguinal canal: anteriorly the external oblique aponeurosis and conjoint tendon, muscle laterally posterior fascia transversalis and the conjoint tendon, superiorly conjoint tendon muscle, and inferiorly the inguinal ligament. The inguinal canal contains the spermatic cord, ilioinguinal nerve, genital branch of the genitofemoral nerve, and in the females the spermatic cord is replaced by the round ligament. Spermatic cord contains the vas, the testicular artery, cremasteric artery, lumbiform plexus, and lymphatics. As you can see that the inguinal canal represents a physiological weakness in the anterior abdominal wall, and the body mechanism to reduce the risk of hernia include the obliquity of the inguinal canal, and there is a shutter mechanism by the conjoint tendon contraction. Here just some epidemiology about the groin hernia. Groin hernia are found about 5%, probably 10% of the male population. It's the commonest type of hernia, 86 of all hernias. It is more common in males 5 times, and the inguinal represents the commonest form of hernia, 96, and 3/4 are indirect, 1/4 are direct. And if we find an inguinal hernia, expect 20% is present on the contralateral side, and the right-sided hernias are commoner than the left side due to the late descent of the right testis compared to the left. Femoral hernia represent 4% of all groin hernias. This slide will just illustrate the differences between inguinal and femoral hernia. Inguinal are common in males, femoral common in females, and the inguinal pass through the inguinal canal, here through the femoral canal. The inguinal hernia, the sac is usually above and medial to the pubic tubercle. Here the neck of the sac is below and lateral to the pubic tubercle. The inguinal hernia has a less chance or less risk of strangulation compared to the femoral hernia, which has a higher risk of strangulation. Inguinal hernia potentially could be treated without surgery with a truss, but femoral hernia surgical intervention is a must. Inguinal hernia, the sac mainly contains bowel or could contain bowel, but the femoral hernia it usually contains omentum, less commonly contains bowel. And this slide just to illustrate an indirect hernia. The indirect hernia, as we said, are more common in young, and the abdominal content through hernia through the deep ring into the inguinal canal. It can come out through the superficial ring and descend down to the scrotum. The descent could be complete or incomplete. And this just slide show you the areas of the weakness in the anterior abdominal wall in the groin. So this is the site of the indirect hernia through the deep ring. Here is the site of the direct hernia, which is through the Hasselbach triangle, and the landmark is the inferior epigastric vessel. Here is the site of the femoral hernia, which is usually below the inguinal canal and medial to the femoral vessels. Direct hernia are commoner in all people, and the content of the hernia goes directly through the Hasselbach triangle, and the landmark is the inferior epigastric vessel, as the hernia lies medial to the inferior epigastric vessel. Here see the Hasselbach triangle, and the hernia is medial to the vessel or inferior epigastric vessel. And this slide just to show you how the hernia presents itself in a male or female patient in the groin. 7% of all the surgical outpatient visits due to the presence of a groin hernia or inguinal hernia, to be precise. 96, as we said, are femoral, and 4%, 96 are inguinal, and 4% are femoral, bilateral in 20%, and the risk lifetime risk of inguinal hernias are 10%. More common in males, 9 to 1. 1 to 3% of the young population, young children, could be affected by inguinal hernia. As the people becomes older, the risk of inguinal hernias becomes higher, and the main type is usually direct type of hernia, and as we said, is a very common cause for visiting the outpatient clinic in surgery. Again, it's commoner in males, and there is a definitive familial tendency, and we mentioned before. Presentation: pain could be localized or referred pain or generalized pain, nausea, vomiting, constipation, and urinary symptoms. Initially, it is easily reducible, but with time, it becomes irreducible. Strangulation ensures when the visceral content of the hernia becomes twisted or entrapped, and its blood supply has been compromised. Diagnosis is usually clinical by inspection, and probably when the patient is standing is the best way to examine it. Cuffing will cause the increase in the size of the hernia. If the hernia is above and medial to the pubic tubercle, then this is an inguinal. If it's below and lateral to the pubic tubercle, this is a femoral hernia. The inguinal hernia could descend to the scrotum. Anytime you feel a scrotal swelling, you should feel the other side, and you should look for scars from previous surgery or trauma. When you palpate, if you cannot get above the swelling, then this is very likely to be a hernia. Should also look for consistency, temperature, tenderness, and fluctuation. You should try to reduce the hernia. Initially, you should ask the patient to reduce it by himself, and in case you cannot reduce the hernia, then the likelihood of that hernia to be femoral is higher than that indirect, and that's also higher than being a direct hernia. Expansile cuff impulse: when you ask a patient to cough, you could feel the cuff impulse. Deep ring occlusion test: you locate the deep ring, which is about ½ inch above the midpoint of the inguinal ligament, and try and reduce the hernia, and then ask the patient to cuff. If there is an impulse or swelling appearing, then this is a direct hernia. If there is no hernia visible, there is no swelling, no cuff, then this is an indirect hernia. When you reduce the hernia, if you feel gurgling, there is a small bowel. If it feels firm and granular, this is omentum. And always, if you find a hernia on one side, look for a hernia on the contralateral. Percussion. The note of the percussion depends on the content of the hernia. If there is bowel, you can induce hyperresonant or tympanic note. If there is omentum or fat, the note will be dull. Ultrasound is a very sensitive and specific way to check for hernias. In the past, we used to do herniography by injecting contrast material into the sac and doing fluoroscopy, and this is done for clinically unclear when the hernia is too small to be felt clinically. Management. Non-operative watchful waiting is acceptable for asymptomatic or minimally symptomatic inguinal hernias. A truss is one way to manage hernias, especially in surgically unfit patient. Surgery is the mainstay of treatment, and it implies using mesh. The standard treatment is open mesh repair, Liechtenstein, which is the commonest way of repairing hernias. It's tension-free. In the past, before the era of the mesh repair, we used what we call tension-free suture repair, such as Schuldeis, Bassini, or Darling repair. But these tend to have high recurrence, and the gold standard is mesh repair. Laparoscopic repair is a new method and gaining popularity. Two main approaches: transabdominal preperitoneal repair or totally extraperitoneal tip repair. This slide just to illustrate the advantages and disadvantages of performing laparoscopic repair compared to open mesh repair. And you can see that the advantage is quick recovery, less pain, fewer postoperative complications, and less risk of chronic pain. But on the other hand, the disadvantages of doing laparoscopic repair, you need to have highly skilled, experienced surgeon. It may take longer time to do it, and if it's done by an inexperienced surgeon, the risk of recurrence is quite high. Complications. Probably 1/10 of all people undergoing hernia repair will suffer from one or more of these complications: foreign body sensation, chronic pain, ejaculation disorder, mesh migration, mesh folding or meshoma, infection, adhesions, and erosion into the peritoneal cavity to the abdominal viscera. In the long run, the polypropylene mesh might degrade due to the temperature or heat effect. Obstructive azoospermia is another potential complication. This is a femoral hernia, and the femoral hernia comes out through the femoral canal. Femoral canal is a canal through which the femoral artery, vein, and nerve leave the abdominal cavity. It's a tight, small space, but having said that, it can sometimes transmit abdominal content, fluid, omentum, and occasionally intestine. There will be a bulge below the inguinal canal or inguinal ligament. and the bulge is usually below and lateral to the pubic tubercle. These types of hernias are rare, and if they are going to happen, they are common in females. Due to the anatomy of the femoral canal, the risk of strangulation is higher compared to the inguinal hernias. And here, just to illustrate the femoral hernia and its relationship to the inguinal ligament and femoral vessels. Umbilical hernias, they are common hernias, comprise 10 to 30% of all childbirth, and usually it's due to the delay of forming of the cicatrizing tissue at the site of the umbilicus. Even if the patient does not, or the individual does not have a hernia at childbirth, later on in life, this scar tissue might weaken due to various causes and present later on in life as umbilical hernia. Usually they occur in elderly and middle-aged women who had children or pregnancies. This is an incisional hernia. You can see that's the big incision, and this is incisional hernia here and there. Any type of surgery will make a defect and weakness in the abdominal wall, and that weak area is a potential site for hernia development later. Statistically speaking, the risk of incisional hernia is 2 to 10% of all abdominal surgery, and after any surgical repair of the incisional hernia, there is a high risk of recurrence, 20 to 45%. This is an epigastric hernia, and these hernias usually occur anywhere between the umbilicus and the lower part of the rib cage, the midline, and usually they contain fatty tissue, and they represent weakness of the linea alba or the scar tissue in the midline. Usually they are painless, but on the other hand, usually they are irreducible as a patient is unable to push them back into the abdominal cavity.